leaders in various areas who are very farsighted when it comes to their own activities and to concerns within their enterprises, are very short-sighted when it comes to the area of public policy, and allow themselves to be led by small advantages to foster and favor policies which ultimately redound very much to their disadvantage. In the medical case, the initial inducement is that here is a new source of money. And presumably this is why organized medicine has been schizophrenic about the trend toward government involvement. It has, on the one hand, tended to protest against the move toward socialized medicine. It has, on the other hand, engaged in activities which have promoted that development. Most recently, by a commission established by the American Medical Association on the cost of medical care, which it would be very hard to describe as a balanced commission. But although initially it might appear as if the purveyors of medical care could get additional resources by tapping the governmental till, that is a transitory phenomenon. When the government is taking over any activity, there is more money available. But what typically happens is once the government has taken it over, the situation changes. There are no more votes to be gotten by taking it over some more. You have to move on to new fields and take over new areas in order to get some new votes. And the result of that is that those areas already taken over get starved. And instead of there being more resources available, there are fewer. The most obvious example, the most striking example, is Great Britain. As you know, national medicine, socialized medicine, was introduced in Britain immediately after World War II. It is now some 30 years old. There have been a number of careful studies made of the total amount of money now being spent in Britain on medical care, and the amount that you might have expected to be spent if you still had an essentially voluntary private system. Estimates made by seeing what the relationship was before the war between income and expenditure on medical care. Estimates made by seeing what fraction of income people in other countries spend on medical care. These estimates show in no uncertain terms that you would be having a larger total sum of funds devoted to medical care in Great Britain today if you did not have a state system of the provision of medicine. In addition to the fact that the ultimate result of a government takeover is less resources, you invariably get lower quality and a lower quantity of medical care. The experience of the United Kingdom is again clear. I am going to cite from a study that was made by a British physician, Dr. Max Gammon, who spent 5 years studying the British Health Service. He wrote a report in December 1976 on the public provision for medical care in Great Britain, and I quote, "National Health Service brought centralized state financing and control of delivery to virtually all medical services in the country. The voluntary system of financing and delivery of medical care, which had been developed in Britain over the preceding 200 years, was almost entirely eliminated. The existing compulsory system was reorganized and made practically universal." He goes on. No new hospitals were, in fact, built in Britain during the first 13 years of the National Health Service. And there are now, in 1976, fewer hospital beds in Britain than in July 1948 when the National Health Service took over. And I might add, of the hospital beds which there are now in Britain, 2/3 are in hospitals that were built before 1900 by private medicine and by private activity. Mr. Gannon, in a rather amusing way, developed what he called a theory of bureaucratic displacement. He argued that whenever you have any organization taken over by a bureaucracy like a government, what tends to happen is that input goes up and output goes down, that useless work tends to displace useful work in a further extension of Parkinson's laws. And he illustrated it with hospital service in the United Kingdom. He took the 8-year period from 1965 to 1973. In that 8-year period, the hospital staff the number of people, went up 28%. Incidentally, administrative and clerical help went up 41%. But what about output? What about what they were producing? Input was up. Well, he measured output by the average number of beds occupied daily. It turned out that the average number of beds occupied daily went down by 11%. And he hastened to go on to explain that the decline in the average number of beds occupied was not for want of patients, that at all times there was a waiting list in the neighborhood of 600,000 people waiting for hospital beds. I don't know how many of you know the scandals in Britain about the waiting periods for what is regarded as optional or postponable surgery, including, for example, bypass operations for heart problems. There are stories of people who waited 3 years to have a bypass operation because that could be postponed. Indeed, some of them managed to die before the operation was performed. But 600,000 people waiting on the waiting list, and for rather more readily and more obviously postponable operations, the wait may be much longer than 3 years. Well, Britain is one case. I might add also that, as you know, physicians have been fleeing Britain when they could. The number of physicians annually emigrating from Great Britain to other countries is about 1/3 the number of physicians being graduated each year from their medical schools. As you also know, the process is inexorably moving in Britain. The National Health Service in Britain permitted private practice to exist alongside state practice, but to a very limited extent. There is now strong pressure and movement to try to eliminate private practice altogether and make it compulsory that all practice be in the socialized sector. On the other side of this, there is growing up a voluntary health insurance arrangement with nursing homes and the like to supplement the inadequate governmental provision. Let me turn to Sweden. I quote from a report by Dr. Gunnar Bjork. In Minnesota, I should be able to pronounce a Swedish name, but it takes more than physical connection. He's a professor of medicine at the Karolinska Institute. He's a head of the Department of Medicine at a major hospital in Stockholm. He formerly was, and maybe still is, a physician to the King of Sweden. He gave a paper in 1976 at the University of Chicago on, quote, how to be a clinician in a socialist country. And I quote from his paper, "It is obvious that the